Greetings, good morning, good afternoon, or good evening, depending on what time you're watching this video. Thanks for joining in today as we spend about the next hour talking about the national guidelines for the field triage of injured patients, and in particular, how we have adopted these new national guidelines to meet the activation of our trauma team here at St. Joseph's. So for those of you that don't know me, hello, my name is Steve Lyman, and I am the trauma educator here with the trauma program at St. Joe's. So thanks again for joining me, whether you're here voluntarily or being voluntold. I appreciate your tuning in and hope that you find about the next hour of information to be very helpful to you working in our emergency department. So the content for the talk really comes from the American College of Surgeons Committee on Trauma new national guidelines for the triage of trauma patients. And these are field triage guidelines, absolutely, but they're tangential to what we do because our pre-hospital colleagues first have to get on scene, assess their patient, and then ultimately determine, do they need to go to a trauma center, and then ultimately bring them to us where we will hopefully activate our trauma team and get them taken care of. So the guidelines are fairly universal from the standpoint of the pre-hospital setting all the way through us here in definitive care. And there's a good amount of information at this website listed here, the American College of Surgeons website. If you want to learn more about the trauma triage guidelines, how they were put together, how they evolved, there's a great reference article that appeared in the March 2022 issue of the Journal of Trauma that's up there for your perusal. And if you are an educator yourself or you're working in the pre-hospital setting and you want to bring a similar presentation back to your agency, then you're welcome to do so. You'll find some slide proofs at this website as well. So it's there for you to take avail of. And then at the end, I will give you my email address. And if there's any questions you have after this presentation, feel free to reach out to me. So the objectives are fairly straightforward today. We're going to talk about the process by which we went from the old trauma triage guidelines to these new trauma triage guidelines. We will obviously review the guidelines, and then we will review how we have integrated them into our trauma activation criteria here at St. Joseph's. So the trauma triage guidelines, as they are revised, actually came out in late 2021. They were published, as I mentioned earlier, in the March 20th issue of the Journal of Trauma. And even though they came out in March of 2022, the state Department of Health was a little late in adapting the guidelines. Not the fault of the state, but the way particularly pre-hospital care is kind of managed, and particularly the way trauma centers and the trauma system here in New Jersey is set up, it's done by statute. And unfortunately, the old statute, or the current statute, actually calls for trauma triage to follow the CDC guidelines on trauma triage, which is great and fine, except the CDC got out of the business of doing trauma triage, turned that over to the American College of Surgeons. So it took a little bit of time to kind of meander through the politics of Trenton in order to get final approval from the DOH for us to implement these guidelines. Not that we didn't really kind of start implementing them almost as soon as these guidelines came out. So why do we need the guidelines? What's the purpose of the guidelines, and why were they updated? Well, first of all, we being not only hospital-based clinicians, but also those of us that, including myself, who work in the pre-hospital setting, we want to make sure that we achieve optimal outcomes of patients from point of injury through definitive care by really determining what is the most appropriate destination for them within the medical system, and particularly the trauma system. We honestly want to make sure that we're taking the right patient to the right place at the right time, or within a very short time span. We're all familiar with the construct of the golden hour. Well, we really are now operating on the construct of the platinum 30 minutes, getting the patient off scene into a trauma bay within 30 minutes of injury. It's a lofty goal from a national standpoint, but it's something that we quite ably accomplish within our pre-hospital system and our trauma system here in Patterson. And it's something certainly I think that we're all fairly proud about. It means the patients are getting to the hospital very quickly, and we're able to provide them definitive care long before they start to decompensate, which is less than optimal. We also wanted to minimize the variation in destination decisions that our pre-hospital colleagues would have to make. So if they get on scene and they assess the patient needing a trauma care, then we want them to go to the right trauma center that's within their catchment area as quickly as possible, as I've already mentioned. So why was the update done? Well, the update was really done because the last set of trauma triage guidelines, which were put out by, as I mentioned earlier, the Centers for Disease Control, came out in 2011, which means they were constructed from about 2008 through about 2010, and then published in 2011. So following kind of that line, that timeline, that chronology, you're seeing that the triage guidelines that were in effect up until we now have ported over to these new ones, we're now close to about 12 years old. That's way too old to be operating under any level of clinical practice guidelines. Clinical practice guidelines really should be turned over every 2 to 5 years at the absolute max. So we had definitely kind of gone way beyond the useful shelf life, if you will, of those guidelines. So they needed to be updated. And why did they need to be updated? Because there's been a lot of research that's been done in the last decade and a half that has really changed some of the basic tenets in how we operate, both in the pre-hospital setting and here in definitive care land, but also the way we treat the patients, interventions that we do, and new mindsets on how they need to be triaged. We want to reduce the time and variation in making pre-hospital decisions on where to transport these patients. And by doing so, get them going to the appropriate trauma center as quickly as possible. You'll hear me say this a couple of times throughout this presentation. These are national guidelines. So they are predicated not on being in New Jersey, where we've only got 2 levels of trauma centers, and a level 1 and a level 2 trauma center really almost operate at the same level between the two of them, versus states like Minnesota or Missouri or Iowa or Texas, where you have 3, 4, 5 levels of trauma care. Some of them can provide very, very good, very decent definitive care. Others are nothing more than resuscitation stations to stabilize and then move on, which ultimately delays getting a patient to definitive care in some cases. So these guidelines were trying to figure out a way to minimize that as well on a more national basis. But here in the state, anything we can do to decrease the amount of scene time and decrease the amount of field time before they come in for definitive care is certainly exactly what we want to do. We also wanted to make sure that we reduce under triage and over triage in the way these patients are routed. Now, under triage and over triage are a very big deal for trauma centers, because obviously when you under triage somebody, it means the patient came in and they weren't as sick, they were sicker than we thought they were. As a result, we probably didn't treat them as seriously as they should have, and we needed to. And this increases mortality and morbidity for these trauma patients. So we don't want that to really ever be a big number. The American College of Surgeons has set a threshold of 5% or less for under triage decision making. Then there's the opposite end, which is over triage. Over triage means the patient came, we devoted a lot of resources to them, and in hindsight, they really didn't need those resources. And the American College of Surgeons realizes that, you know what, over triage isn't the worst thing in the world. Under triage is really, really bad. So for over triage, they allow us about a 30% over triage rate. So obviously, they understand that this isn't a perfect world. Patients are going to come to us, and we're going to be getting variations of, stories on what their mechanisms of injury were, what their condition was in the field, ultimately till they come into our trauma bay. And we may over triage a large number, which we tend to do. That's okay. What we don't want to do is under triage a lot. So here at St. Joe's, we do pretty well. For a 5% over triage threshold, we're usually operating somewhere around 2.5% under triage, which is really good. From an over triage standpoint, I believe our last statistics were something on the order of about 6 or 7% over triage, which again, considering the fact that you can get a 30% over triage and still be within bounds from the standpoint of the American College of Surgeons, it's pretty darn good for us as well. So again, we're doing a good job, but there's always room for an improvement. We can always make those numbers smaller and smaller and smaller. And the optimism here with these new guidelines is that we'll actually make that happen. So only time will tell. So the update process. So in order for these guidelines to be updated. The American College of Surgeons did it the right way. They went and they were very inclusive with the groups of clinicians they went back to and sought information from. They went all the way back to the pre-hospital setting and got our colleagues in the pre-hospital setting, EMS, involved. In addition to that, they certainly got a lot of input from emergency and trauma clinicians like you, like me, like our physician colleagues, etc. And they did get a lot of input from them. They distributed surveys to over 29 national organizations that represent EMS, emergency care, and trauma. And from our standpoint as receivers in the definitive care setting, the American College of Emergency Physicians was part of this list, the Emergency Nurses Association was part of this list, and the Society for Trauma Nurses was part of this list. And I believe the Association of Critical Care Nurses as well were part of that list. So look at nursing was very well represented, as was emergency medicine. So we certainly got some good input from our stakeholder organizations, and we didn't go unheard. There were over almost 4,000 responses to this call for input. And the American College of Surgeons took these responses very, very seriously. They convened an interdisciplinary panel of experts that, again, spanned the globe on both expertise and where they practice, from pre-hospital clinicians all the way through to definitive care. And they took a look at the survey results. They took a look at the responses. They took a look at the literature, and they ultimately put together the final guidelines as we present them today. Now, as some of you may know, doing really top-level research in trauma is really, really hard. The gold standard randomized controlled trial studies are very hard to do in trauma. Not that they can't be done, but they're few, they're far between. So we really needed to resort to really what was a second tier, but well, not as good, almost as good as we're going to get, studies which are called systematic reviews. And a lot of these were systematic reviews with meta-analysis, which really is a fancy statistical term to show it was as good a data as you can possibly get outside of doing a randomized control trial. So a lot of the input that went into there was by trying to find these systematic reviews. And where you couldn't find systematic reviews, they were looking at one-off studies, observational studies, retrospective studies, and then ultimately, anecdotal care, which we don't hold as a high level of evidence, but we also can't discount the fact that anecdotal evidence certainly has its place in the care we provide. And there was a very rigorous process for looking at the current criteria, which is the 2011 criteria, and then pumping that up and then matriculating that into what became the 2021, ultimately published in 2022 criteria. And you're going to see as we go through this, comparing the old with the new, particularly if you're familiar with the old still, you'll see that there were some changes that were made, nothing really outlandish. You'll see there were a lot of clarifications made, a lot of simplification of terms were made, a little bit more separation between special populations and the general trauma populations. We see things like that, but there wasn't anything major that came out of it. But the format would change. And the format was probably one of the bigger changes that we'll see. And we're hoping that that format change will make the system, the pre-hospital system, a little bit easier to matriculate for our clinician colleagues in the pre-hospital setting, for them to look, assess, and then make triage decisions a little bit quicker. And also, again, minimize that over and under triage that we talked about. So for those of you that are familiar with the 2011, now the old trauma triage guidelines, this is a copy of the algorithm that the CDC put together, again, from about 2008 to about 2010. You can see it's a very linear approach. It really looks at 4 major criteria, and it's one of those algorithms that if this, then this, if not, then this. And while these algorithms certainly are decent, they're cumbersome to use, and particularly in the pre-hospital setting, they're very difficult to use. They're very difficult to keep in your mind, and they're more difficult to try to matriculate while you're caring for the patient, trying to look at an algorithm. So you'll see with the new trauma triage guidelines, this algorithmic approach went away. The way we looked at it is everything was kind of linear. So we looked at first vital signs and level of consciousness, which we really called physiologic criteria. The thing about in the old system, we looked at the Glasgow Coma Score as an entire entity. We looked at all three components of the Glasgow Coma Score and then made triage decisions based on that. That has changed a little bit, as you'll see. We also looked at their overall vital signs, but more importantly, it wasn't so much looking at their vital signs, as it was looking at their respiratory rate and it was looking at their systolic blood pressure, which even though we've kept those parameters in the new guidelines, you'll see that there have been some variations in how we're looking at assessing vital signs in general with regards to this criteria. The next thing that they were kind of looking at was the anatomy of the injury. What was the anatomical location? And if the anatomical location was important, they looked at things from that perspective. They also looked at mechanism of injury or evidence of high energy impact. And last but not least, they had a column which was kind of special patient populations or special system considerations. So that was the really 4-box linear approach we had in the past. You're going to see there's still a 4-box approach there, but because it's not a linear approach, and more ordinarily, it's not an algorithmic approach, the optimism is that it'll be a little bit more user-friendly for our pre-hospital colleagues, and even for those of us in the definitive care setting. So this is ultimately what the new guidelines look like. There's still 4 boxes, but they're kind of bifurcated into 2 different categories. There's the red category, and then there's the yellow category. The red category are those injuries, those mechanisms, those items that are high risk for serious injury. So these are the things that every patient who has one of the criteria should be routed to an appropriate high-level trauma center. And we'll talk about what a high-level trauma center is again, because we're in New Jersey and we do things a little bit differently than some of the other states in the country. Then there's also the yellow criteria. The yellow criteria are those injuries that are moderate risk of serious injuries. So those would be things that, okay, if you weren't going to go to your higher order level trauma center, you could certainly take them to a lower level trauma center, depending on what your local protocols are and how your state designates trauma centers, and then what the distance is between your trauma centers. So let's look at these a little bit more closely. We'll notice that, again, it's not an algorithm anymore. It was simplified to align with the way EMS clinicians are taught to assess and gather information. So since we're already kind of feeding into what they already recognize, it should make decision making a little bit quicker. And it reflects ultimately how assessments are done on scene. Not that assessments are done for EMS clinicians any different than they are for those of us in the hospital. It all starts off with uncontrolled external bleeding and follows through the ABCs. But again, the way it's done in the pre-hospital setting, this particular chart tends to follow that approach a little bit better. Certainly better than the old algorithmic approach. And ultimately, if we can get our pre-hospital colleagues to come to a triage decision sooner, they can get them off the X or off the point of injury quicker, and then ultimately to definitive care more quickly. So let's look at the red criteria, high risk for serious injury. At the bottom, it says the red criteria, patients should be transported to the highest trauma center available within the geographic constraints of a regional trauma system, okay? We do run a regional trauma system here in New Jersey, but our regional trauma system is population-based, and there's only 2 levels of trauma center in the state of New Jersey. It's a level 1 or a level 2 trauma center. And really, for the most part, with the exception of just a couple of outlying hospitals, not St. Joe's not being one of them, is that our level 2 trauma centers really operate at a level equal to our level 1 trauma centers in the vast majority of the care we can provide. Absolutely, the level 1 trauma centers typically can provide a little bit higher order care for some of the subspecialties of surgery. But as a general rule, the vast majority of patients that come to a level 2 trauma center in New Jersey will stay at that level 2 trauma center. It's not going to be a kickoff station where, okay, we're going to take care of some of their injuries, but some more commonplace injuries that a level 1 trauma center can take care of, we're not able to take care of. That's really not the way our system is set up in New Jersey, which I think is very good. So, Any patient meeting red criteria in the state of New Jersey will be routed to the closest trauma center, level 1 or level 2. Now, granted, if you are in a geographic area, let's say like Jersey City or Newark, where you are could be right on the cusp of, halfway between a level 1 and a level 2 trauma center, then the predilection would be possibly to go to a level 2 trauma center. But that's really not so much the case outside of really kind of Newark, Jersey City location. Hackensack for Hackensack University, certainly Patterson for those of us here at St. Joe. We have a significant enough distance away from that level 1 trauma center that really, unless we are kind of to the south and really on that cusp, on that borderline, then these patients are predominantly going to come to level 2 trauma centers. So let's take a look at these criteria. Let's talk about them, and then we'll kind of compare and contrast them to the old trauma triage criteria, which, hopefully most of you are familiar with. If not, then you don't have as much learning to do because these new criteria will be right up the alley. So first of all, these really kind of used to be anatomic criteria. We now call them injury patterns. Okay, but a lot of these have stayed the same or been clarified. There's only been one significant change, and that is we are now recognizing the use of pre-hospital tourniquets, wound packing, and direct pressure for bleeds that are otherwise uncontrolled. So now, whereas it wasn't in the old criteria, because when the old criteria came out again back in 2010, 2011, tourniquets were kind of last resort, not even kind of being used almost ever in the pre-hospital setting, whereas today, as we know, they're very commonplace. So any patient who had to have a tourniquet to stop bleeding, had to have a wound pack to stop bleeding, or has to have direct pressure continually held on a wound that is continuing to bleed, needs to go to the highest level trauma center available. So they go to a level 1 or level 2 trauma center, hence us. The other areas were clarified, and really the clarification here was just terminology was made less confusing. Some of the terminology in the past really got confused pre-hospital care providers. So I think that the way the verbiage is now, it's less confusing. And again, it'll allow these pre-hospital clinicians to make quicker field triage decisions and transport patients a little bit quicker. Clarified here was really penetrating wounds to the head, the neck, the torso, and the proximal extremities. That didn't really change too much, to be very honest with you. It pretty much is almost the way it was before. Skull deformities, it's now suspected skull fracture. I believe the old terminology was skull fracture, which is almost no way to ultimately tell that in the field without radiology. Although if you could feel a deformity and you feel a mushy skull, then you can assume there's probably a fracture there, but not necessarily, certainly not definitively, as the old trauma triage criteria kind of read a little bit more definitive than that, which again was confusing. Suspected spinal cord injury, again, if you suspect there's something going on, there's there's either sensory or motor deficits, to a trauma center. Chest wall instability, leaving it at that, but also if there's any deformity, if you suspect a flailed chest, then once again, transport. Whereas the old terminology tended to be a little bit more definitive, that there were multiple broken ribs or there was a flailed chest, which once again is not something you can always take away from when you do your patient assessments in a pre-hospital setting. And if you suspect a pelvic fracture, okay, any kind of mechanism of injury that's great enough to result in a pelvic fracture needs to come to an appropriate trauma center, okay? And then those that really didn't change that much or change at all were multiple long bone fractures, crushed, gloved, degloved, mangled, or pulseless extremities, and then amputation above the wrist or above the ankle, which really is even probably below that now. Most of the patients that we find that have any degree of amputation to any extremity are usually taken to a trauma center over a non-trauma center. So that is the injury pattern, which really kind of used to really be kind of anatomical criteria. Not any significant changes there, other than they've added the tourniquet and wound packing to trauma triage criteria. One of the things they tried to do, and they did a good job here, thankfully, was they started looking at age-related changes to the vital signs rather than just chalking them off, particularly for pediatrics, that it's just based on age and kind of you had to then fumble around for another card to figure that one out. So we kept the term mental status and vital signs here. But again, they've done a couple of things that have kind of honed things down a little bit better, and I think made them better from my point of view. So we'll start at the top and work our way down here. So the top two arrows for all patients would be any patient who is sustained a traumatic injury that now has respiratory distress or either needs respiratory support or starting to head down that slope of progressing into respiratory distress or need for respiratory support. They need to go to a trauma center. I think that's fairly straightforward. And anyone who's hypoxic or continually hypoxic on room air. Hypoxia, now again, we're looking at typically a pulse ox under about 90%, knowing that a normal pulse ox is somewhere around 93 to 94%, or that's really kind of the sweet spot to keep somebody at this point in time. The other thing you'll notice under age 10 to 64, so the adolescent to the adult population, and then over 65, our geriatric population, is if their heart rate is greater than their systolic blood pressure, they should be transported to a trauma center. So what does that mean? It means, first of all, that we're looking now not only at systolic blood pressure as an indicator of hemodynamic status. We're also looking at their heart rate, which I think we were missing tremendously in the old trauma triage. Systolic blood pressure alone is not a great indicator. In fact, systolic blood pressure alone has almost no base of evidence. I'm not almost surprised. I'm really actually very surprised they kept that in here. I just think it is so much part of the dogma of how we look at patients that they just didn't want to take it out at this point in time. But they did put in this heart rate greater than systolic blood pressure. So for those of you that are crack aficionados out there, I don't mean that you like crack, I mean that you're right on top of things from a trauma standpoint, then you'll recognize that the term applied here is the shock index. And the shock index, particularly in the adult population, are again greater than about 10 or 12 years of age to adult and then geriatric status, basically says you take the heart rate and you divide it by the systolic blood pressure. If it's greater than 1, then there's a high likelihood you could be looking at hemorrhagic shock, a high likelihood we could be looking at either operative intervention or interventional radiology intervention, and or the need for critical care admit is pretty high. So we're now looking at multiple parameters, which I think is a good thing. The shock index has been validated and it's being used not only in trauma patients, but hemorrhage from other sources. It's used in a variety of neuro patients. It's being used in cardiovascular patients. It's being used in pediatric patients, OB patients. So if it's not something you're familiar with, then you should get familiar with it. Look up the shock index. If you want to go to YouTube, you can look up my name under YouTube, and you'll see that I've got 2 videos up there that talk about the shock index, one from the pre-hospital perspective, and the other one, things that you need to know as a hospital-based clinician. And I do urge you to spend about an extra hour or so of time going out and learning about the shock index. It really is important for us to know. So that kind of wraps out anything new under this mental status vital sign category. One thing that's a good change, is not new, but it's a really good change in my estimation, is that we now, instead of looking at Glasgow Coma Score in its entirety, we have now pulled out the motor component of the Glasgow Coma Score, which evidence has shown that that's the most reliable portion of the Glasgow Coma Scale to be driving clinical decision making off of. And we've said if it's a motor score less than 6, so if they're not a perfect motor score, which is 6, then we need to be thinking neurotrauma, transport as appropriate to the trauma center. We don't really care, to be honest with you, about what their eye opening is and or what their verbal response is. We look at their mobile. That mobile tells us more globally what cognitive function is going on than the other two do as well. Now, you're going to see when we look at our own individual criteria here at St. Joe's, we still are looking at Glasgow Coma scores in their entirety. That was a decision that was made by the group. We stand by it and we'll continue to look at it. But in your own practices, bear in mind, Glasgow Coma scores are great. That motor score, particularly if it's aberrant at all, is a better indicator than the totality of all 3 parts. Okay. The other thing that is now added is we've added kind of a hypotensive criteria for children 0 to 9 years of age. And basically what that is that if their systolic blood pressure is less than 70 plus 2 times their year in age combined, then they're hypotensive. So for example, let's say it's a 3-year-old that comes in. So 2 times their years in age would be 6, added to 70 would be 76. So a blood pressure less than 76 millimeters of mercury on them would be considered hypotension. Okay. So that's new. That's in there as well. Again, it's easier on the pre-hospital clinician to use this particular rule of thumb than it is to try to figure out age and then look on a chart or on the back of their ID badge with bloody hands as to what's going on. And then we've kept the good old systolic blood pressure less than 90 for adults. Remember, the systolic blood pressure is less than 110 for our geriatric population. Okay, our geriatric population is elderly. They tend to have higher blood pressure. Therefore, the threshold for hypotension is a little higher for them. There's nothing new. If you didn't know that up until today, then now you know. And then last but not least, at the top there, respiratory rate less than 10 or greater than 29 a minute. That is the same as it was in the old criteria. So nothing has changed there. So again, you do see, though, most ardently that we're looking more toward respiratory distress and respiratory function. And we're also looking at that shock index now. Very, very important to take away from. That kind of wraps up the red criteria. Okay. Not significant number of changes there, but I think there are some important changes that are there. Let's move our attention now to the yellow criteria. Mentioned earlier, this is moderate risk for serious injury. From our standpoint here in New Jersey, it's still routing the patient to a level 2 or level 1 trauma center within your region. So let's talk a little bit about these. First of all, we've got the good old mechanism of injury there, and we have changed a couple of things under mechanism of injury. The one thing that's changed the most is the child who is not restrained or is unsecured in a car with significant impact. Car has significant impact and the child was not restrained or was unsecured or wasn't in a child safety seat at all, or the child safety seat wasn't appropriately placed, then we consider now taking them to a trauma center to be checked out. Okay. But everything else kind of is largely clarification stuff. Clarification about vehicle intrusion, something we do need to listen to, something our pre-hospital colleagues need to communicate to us during our missed handoff, is that there was intrusion. And where was the intrusion at? And how much intrusion was there? Generally speaking, if it's greater than 12 inches of intrusion on either the roof or either the passenger side or the driver's side doors, that's significant. Okay. That's trauma center routing, because the amount of force to push the door in 12 inches is enough to push it into the occupants and cause blunt force injury. Okay. If it's 18 inches on either the motor compartment or the trunk compartment, or we'll say the front of the car or the rear of the car, then again, that's pretty significant. And again, need for trauma routing criteria. Anytime you have a rider separated from a transport vehicle, this is a little bit different. It used to be a motorcyclist hit greater than 20 miles per hour. It's now taking into account there's not only motorcycles out there, but there's ATVs that are out there. There's horses that are out there. There's other things that people ride on. Bicyclists are looked at a little differently. They're looked at as pedestrians, and we'll talk about that in a second. But again, anyone who's on any kind of a motorized or I guess a mammalized mode of transportation, if they get thrown off and there is a significant impact as judged by the pre-hospital care clinicians, then they need to be routed to a trauma center. Likewise, pedestrian or a bicyclist struck, thrown, or run over with significant impact, once again, needs to be routed preferentially to a trauma center. I have seen particularly some bicyclists that took what looked to be very minor hits, but the way they were hit and the way that the bicycle torsed and maybe handlebars hitting them in their rib cage that caused spleen injuries, liver injuries, fractured ribs, pneumothoraxes. So look at we're in the pre-hospital setting, we're looking at things in their totality. As they come into our setting, we'll look at them in their totality as well that way. And then the other thing, and probably the most significant clarification here, was fall from height. In the old trauma triage criteria, it was 20 feet or more for an adult, and it was about 2.5 to 3 times the height for a child's height. They've changed that. It's now all comers, all doers, it's greater than 10 feet. So gone is the 2-story fall. Now is the 1-story fall. So somebody who falls off a step ladder as they're cleaning their gutters and falls and the question always becomes, where does the fall distance? If I'm standing on a ladder, is the fall from my feet or from my head? Well, guess what? We're going to look at it from the head because that's the most vital organ. If that's 10 feet from the ground, then that's what we're looking at as well. Okay. And I think that's always wise to use that as a high road, as far as how you kind of measure from feet to head, where were they on a ladder if they fell. But anytime they fall from a height greater than 10 feet, they should be routed to a trauma center. We're going to talk about kind of low level falls and pediatric falls in a second. So this is just more global now. So what this means now is we're probably going to see more patients coming in that might not have been brought to a trauma center before because they fell 10 feet, 12 feet, 14 feet, and really didn't meet the old trauma triage criteria, but they do now. And then here's another thing in here that's very, very important as well. Need for extrication of entrapped patient. Under the old criteria, it was extrication time greater than 20 minutes. And it was very confusing from a pre-hospital standpoint as to determine what is meant by extrication time. Is that time that either fire department or rescue squad arrived on scene until the time they released the patient? Is it the time that the tools hit the doors and the jaws of life, or the spreaders or the rams or whatever that they read, the cutters were put into motion? That's out the window now. Basically, it's anytime we have to cut someone out of a car. And it means cut, it means that patient is entrapped in that car and couldn't get out under their own accord, other than just the door being, damaged to where they couldn't open it. We see these a lot in my pre-hospital practice, and I also volunteer for a rescue squad where we do technical rescue, so therefore a motor vehicle extrication. That, I can come up on the scene, there's a T-bone accident, the driver can't open their door, and maybe they're frail or maybe they're too big to climb over the center console and get out the other door, so we have to take the jaws and pop the door open and get them out. That wouldn't be considered an extrication. If they were stuck in there because the seat went back, or because the dashboard came in, or because their feet were entrapped, or because the door had pushed them in and trapped them in the car, and we literally need to disentrap them, then that's an extrication. So I just throw that in there to put a little context into what an extrication means, and really what the pre-hospital clinicians now should be thinking about extrication as a criteria for trauma team activation. And then these two are kind of still the same: death in the same passenger compartment. So if somebody was killed in the car and somebody survived, then there's a high likelihood that survivor could have some potentially fatal or serious injuries. So they need to go to a trauma center. And likewise, the use of vehicle telemetry. It's not being used very widespread in the United States right now. There are some states that are starting to use it. I understand California is using it. I think Texas is starting to use it. They've been using it in Europe for quite some time now. This would be like the OnStar or whatever the vehicle telemetry data is in the different manufacturers' cars that look at speed, they look at airbag deployment, they look at other coefficients of force. The thing is that we really haven't been able to matriculate what that truly means from mechanism of injury or injury making potential. The other thing is it's not only vehicle telemetry now, it's also basically personal equipment that we're wearing. Things like our iPhones, particularly our iWatch, our Android watch. We're finding case studies where the activation of these watches during a motor vehicle crash or during a long fall is actually triggered and activated the 911 call, which has brought help to them. So we're starting to see technology, not only vehicle-based, but also personally based, that we're going to have to start giving some consideration to as we evolve. And then the last box is EMS judgment. And this is so critically important. In the old trauma triage criteria, this was a line at the very bottom of the fourth box, and it really didn't give pre-hospital clinicians their due, and I think it does now. So from the standpoint of those of us that are in the field, we need to be thinking at things like low-level falls in children, particularly ages less than 5, okay? And those low-level falls are 2.5 to 3 times their height. Children that are 1 year old who fall off the couch, children that are less than 1 year old who fall off of things when maybe they're not at a developmental point to where they're able to push themselves over and roll and fall off of things right now. Likewise, in our older adults, falls from standing height, falls from sitting height, falls out of bed. These can all be very significant. As we do primary, secondary, and even tertiary surveys of these patients, we need to be looking at them in their totality for all injury patterns. On the elderly lady who falls out of bed, we don't just need to be looking at, did she break a hip or did she have a head injury? Did she break a hip? Did she break her pelvis? Did she break some ribs? Did she break her C-spine? Or did she hit her head and have some kind of an intracranial pathology going on? So we need to be thinking more along the lines with these individuals and in a more systematic approach. We've talked about anticoagulant use in the past, and that certainly is something that is there. Suspicion of child abuse, that is now a criteria really that College of Surgeons wants the children rooted to trauma centers. And the reason for that is trauma centers by nature have better resourcing to be able to investigate suspicions of child abuse. Those individuals who have high resource healthcare needs, so those that are traumatically injured with comorbidities, okay? Those that have developmental and other disabilities, a trauma center may be a better place for them to go, just again, because of the resources that trauma centers have over your community hospitals, if you will. Anticoagulant use is still there. A lot of it is non-aspirin containing. So if you're on an aspirin a day, yeah, you get some antiplatelet effect, but you're not going to truly get the anticoagulation effect that you're going to get with, things like the DOACs or the warfarins or things like that. So again, if they're on ardent anticoagulant use, then that's a consideration we need to be making. And then again, pregnancy greater than 20 weeks, burns in conjunction with trauma, and then ultimately children should be triaged preferentially to pediatric capable centers. Now, that brings up an interesting remark because in the state of New Jersey, there are no pediatric designated trauma centers. There are some hospitals, some trauma centers that have gone out and gotten independent verification from the American College of Surgeons as pediatric trauma centers. St. Joe's is right now wrestling with that ourselves for our next trauma re-verification period in a couple of years. So we can go out and become independently verified as a level 2 trauma center, but the state isn't going to recognize us as a pediatric trauma center. They're going to recognize us still as a level 2 adult trauma, or as a level 2 trauma center, not even called an adult trauma center, a level 2 trauma center designated by the state. So we are expected as a New Jersey state designated level trauma center to be able to treat patients and be able to treat the vast majority of children who would come in. That's not to say children don't come in with complex injuries and may need higher level care, and they can be triaged up to another level 2 trauma center that has pediatric capacity that maybe is greater, or to a level 1 trauma center who maybe have pediatric subspecialties that a level 2 trauma center doesn't. Okay. But generally speaking, children should be triaged preferentially. And we do that for a reason. We do that to make sure the level 2 trauma centers all the trauma centers see their fair, equal distribution of pediatric trauma so that we are able to maintain a level of competence at dealing with that particular injury. All right, so that is kind of a rundown of the trauma triage guidelines as they've been revised from a national standpoint. Let's talk very briefly over about the next 10 or so minutes about how we have integrated them into our trauma team activation here at St. Joe's. So we now have revised clinical practice guidelines that are available on Policy Medical that now talk about the triage of the injured patients and how we activate our trauma teams based on what pre-hospital assessment and reporting is, or what we find when they come here, either by pre-hospital who hasn't called it ahead of time, or those that come in by the front door. And we can get a large percentage of our patients who are trauma that come in by the front door. Right now, our penetrating injuries, particularly the gunshot wounds, are about 40 to 45% come by the front door. They don't come by ambulance. And on any given day, between 7 and 10% of our blunt trauma should come by the front door. So again, no notice type of events. So for those of you that have been in the trauma bay, and I hope all of you have by this point in time, you've seen the trauma code and the trauma alert cards that are up there. We've given these out to all of you as part of your orientation for you to hold on to and look at. And we've changed them up a little bit. We've changed them up so that they do kind of meet based on our best interpretation of these new trauma team activation criteria. And we've tried to kind of simplify them in a way. In simplifying them, we've made more cards. So I don't know if that's necessarily simplification, but I hope you'll find that ultimately it is. So when we look at the old versus the new for trauma code, you'll notice a couple of things. First of all, we now have taken these and we've basically given them kind of a systems look to them. So rather than how they were before, which is anatomic, physiologic, special considerations, which was the old trauma triage algorithm approach, we really are looking at that more from a trauma triage assessment approach. So airway, breathing, circulation, disability, other considerations, and that would include, if you will, anyone who's coming in who has tourniquets applied or wound packing applied. So what we have done is for the anatomical criteria, we got rid of that. And again, each of these has now been subrogated under its individual systematic review. So for penetrating injuries to the neck, the chest, and the torso, again, that is the anatomic or the mechanism or mechanism of injury as it's now combined under that particular category of this card. Traumatic arrest is out on its own. Anyone who was traumatized and comes in an arrest, we know it's a trauma code or it's going to be a TRE. So, one or the other, but if it's going to be considered a traumatic arrest and we're going to work them as a trauma code, it's now given the credence of its own little line, if you will. Also, those that come in with compromised airway, that's found under the airway component of our trauma code card now. For physiologic criteria, what we have done is we've gotten rid of high probability of surgical or operating interventions because nobody's been able to really definitively say whether that is there or not. Probably the use of that shock index, which I mentioned earlier, is probably a good direction to hold, but it's already now integrated there, as you'll see in a second under circulation. And we've also gotten rid of age-specific hypotension because, again, we are now looking at things a little bit more systematically for each of our individual high-risk groups of individuals, that being pediatrics and it being our elderly, which you'll see very shortly in separate cards onto their own. We do have a confirmation of systolic blood pressure of less than 90 still, but we are also looking at the fact that not only are we looking at systolic blood pressure less than 90, what we're also looking at is that shock index. So if they have heart rate greater than systolic blood pressure, that shock index is 1.0 or greater, then again, it's now trauma code activation criteria. And yeah, what we're looking at is a Glasgow Coma score of less than 9 under disability for trauma code activation. It was decided not to migrate toward the motor score per se, although we do need to, again, keep in our mind that the motor score is the more reliable component of the 3 components of the Glasgow Coma score. But somebody who has got that decreased level of consciousness, certainly I think we all will agree, needs to be watched, needs a higher level of care, not only from the standpoint of their airway, but it's, again, the neuro dysfunction that may ensue from the injury as well. Moving down to the bottom, our other considerations really have now kind of been kept their own. Other considerations, and these include transfer patients from other facilities that are continuing to require some kind of transfusion support, which means they're hemodynamically unstable, okay? And then again, ultimately clinician discretion. If the emergency physician or the trauma surgeon or resident feels that that needs to be upgraded to a trauma code, or this transfer is a trauma code criteria, so be it. And then special considerations for older adults, what we've really taken with this is we're going to cover that separately. And most of you may be familiar with the new jury alerts that we have kind of come on board with. So, generally speaking, if a geriatric patient, by definition, greater than 65, I'm not any happier about that number than some of you out there, trust me, but greater than 65, and they meet any of these aforementioned trauma code criteria, they're a trauma code. But then we find those that are the slip and the falls, and they have the potential for having some bad injuries, but maybe they're not overtly manifesting those injuries. We've got a whole different approach, which some of you should be aware of, or most of you should be aware of, which we'll talk about in a minute. From the standpoint of our trauma alert criteria, what we've done there, once again, is we've kind of separated them out under breathing, circulation, disability, mechanism of injury criteria, and even some other considerations. And in particular, under our anatomical criteria, what we did is we took a bunch of those that were in the old card being nothing more than trauma alerts. We have now upgraded them, as you will see, as you saw on our red card. These are actually now trauma codes, okay? So open depressed skull fracture, paralysis, penetrating injuries to the chest, the abdomen, proximal extremities, these are now trauma codes, and you'll see them on the red card, okay? So they're not even now considered as part of an alert criteria. They're a higher level criteria. Things like flail chest, chest instability, unstable pelvic fracture, and with hemodynamic stability and or facial burns where there's no respiratory compromise, these now all are unto themselves under anatomic or mechanism of injury criteria on the new card. Physiologic criteria, what we basically did there is we separated those out, one under breathing. So if breathing is either less than 10 or greater than 29, then that's now breathing on its own. And then we now have under disability, you see, we do have Glasgow Coma score of less than 6, but we also have Glasgow Coma score of less than 14 as well. So 13 or less. So it is kind of staying with the old Glasgow Coma score, but I'm happy to say we've got a motor score on there of 6. So again, we do have that updated component integrated into our response. When it comes to mechanism of injury criteria, as you saw, we have our mechanism of injury criteria over there, which takes into account things such as intrusion into the vehicle, pedestrian struck or thrown with significant impact, rider thrown from a ATV, motorcycle, or similar vehicle, including a horse, and those falls greater than 10 feet. But then we've got a consideration in there for children less than 5 and those greater than 65. And then our special considerations have kind of been distilled down a little bit because we now have some Jerry criteria, which we're going to look at. So, under our old special considerations, a lot of that was really geriatric related. But since we've now kind of taken a little bit of a different pathway with that, it doesn't have to be as verbose on our trauma triage cards. And so we really kind of looked again at mostly pregnant patients with abdominal pain greater than 20 weeks. And then, or actually any pregnant patient with abdominal pain, and then provider discretion as always. And that provider could be provider discretion in the pre-hospital setting or provider discretion here in the hospital. All right, so everything is now Jerry related. We now have a Jerry card for. This is tangential to now the Jerry alerts, which we began doing probably about 4 or 5 months ago now. So if a patient comes in who's over 65 years of age and meets any of the aforementioned criteria for either a trauma alert or a trauma code, then we're going to call them as trauma alert or trauma code. We're more concerned about the geriatric patient who takes those innocuous falls or slides or hits or assaults or even motor vehicle crashes, and overtly there's really no signs and symptoms, but we still need to have a high index of suspicion because they're old and because guess what? They may be on anticoagulants, okay? So the modified geriatric response based and permutated behind how we do things now in the emergency department and are listed on this purple card really are things such as falls, okay, motor vehicle crashes, other significant mechanisms of injury on patients that are on anticoagulation. Now, that's not to mean that somebody less than 65 and also on anticoagulation, we shouldn't have a higher than normal index of suspicion for. We absolutely should. But we have certainly found that in the geriatric population, we tend to miss injuries more in this population outside of the pediatric population than others. So we really wanted to pull this forward and give this group of trauma patients the recognition they deserve, okay? So again, this is what has become, if you will, the internal emergency department Jerry status. So as a patient comes in and they meet one of the above criteria, let's say it's a fall within last 12 hours and they're on, Eliquis, then they will be assigned an ESI-2 for a Jerry activation. You'll initiate the medical screening exam by getting not only a nurse, but also a physician involved as quickly as possible. They will prioritize the care of that patient, getting them reviewed, getting them evaluated, getting x-ray and lab started on them. And if any traumatic injuries are identified, they will then be given a Jerry trauma consult. Now, if the patient comes in and they drop their pressure or they go from being relatively stable to now moving toward either trauma alert or trauma code criteria, then they are upgraded accordingly to a trauma code or a trauma alert. But these are otherwise stable patients who come in that we find out through the course of the medical screening exam that they do have injuries and injuries that need to be reviewed by the trauma team. So when a injury is identified and when a geriatric trauma consult is deemed appropriate by the emergency medicine physician and or resident, then the call goes out. Only it doesn't go out as an overhead activation, just like consults in general. It'll go out as a page. And then a member of the trauma team will have 15 minutes to respond. One of the residents will have 15 minutes to respond after the activation is called. And then the trauma attending will be down to see the patient within 1 hour. And again, these are not paged overhead. So once again, what I would refer you back to for additional information is the emergency department protocols for dealing with now the Jerry alerts for, again, fast tracking, if you will, geriatric patients when they come in with minor mechanisms of injury, but significant enough past medical history, including the use of anticoagulants, that they could have under closer examination some injuries that we're otherwise going to miss. Then we have a code onto separate for pediatrics, okay? Once again, this does mimic a lot of the criteria that we've already discussed, so I'm not going to get into this in any great detail other than you should be familiar with this card. These cards are going to be made available to everybody. They'll be posted in the trauma bay along with the other triage cards as well. But certainly take a look at them. We've certainly gotten away from not having a pediatric trauma card to wanting to have one. And by also noting things like vital sign differences in there and age differences. For our standpoints here, we look at pediatric trauma between the age of 0 and 15 years of age. Anything greater than 15 years of age is considered to be an adult trauma team activation. Disposition is going to be completely dependent on where the attending trauma surgeon wants to admit the patient, whether it's a 16-year-old that goes to the SICU or the PICU. That's completely under their domain. But we do now need to know that we do have this specialized criteria card, which we are using now for the activation. Again, there's nothing in here that is really a big departure from what we've already reviewed with the other criteria we've talked about. We've now just adapted a little bit more to be pediatric centric. And then there's trauma consultations. This is probably less on the purview of the emergency nurses as it is toward the physician group. And certainly those things that are otherwise stable physiology that would result in trauma consultations. Again, nothing really any mind-bogglingly different with this particular section of trauma activations. A trauma team consultation is still considered to be a trauma activation. It's just our lowest order of trauma activation. All right, so in applying these guidelines, we want to absolutely appreciate and understand the context by which we put together these guidelines. We want to obviously understand the applicability to our trauma triage criteria. We want to note that we want to be on the same page as our pre-hospital colleagues. So when they call in and they tell us they're bringing in a trauma, we're kind of operating on the same, page, so to speak. We're going to do sustaining education and training with this. We're already starting this off by doing trauma sims. We'll do some additional education as time from time to time with this as well. And then obviously this will be tracked through the trauma program's performance improvement system as well. So basically, this is an updated process that was inclusive of multidisciplinary clinician input. It's taking us, in my opinion, light years ahead with regards to appropriate trauma triage, both from the pre-hospital setting all the way through to hospital-based operations. The new guidelines do tend to operate a little bit more within the EMS kind of line of thinking, with the caveat being that EMS clinicians will use the criteria, pick up on things quicker, and be able to mount a transport to the hospital, the trauma center much more quickly than in the past. And hopefully we'll minimize over and under triage, which is always an ultimate goal of our trauma program here at St. Joe's. So if you have any questions as follow-up to this, here's my email address. Please don't reach out, and please don't hesitate to reach out and let me know if you need some help. Other than that, like I said, we do have, if you just simply Google 2021 Trauma Triage Guidelines, American College of Surgeons. It'll take you to the ACS website, where you will see a plethora of information that will make you very content to be able to read and become an expert in this as well. So thanks for joining me today. I greatly appreciate it. Be safe, and I'll see you in the trauma bay.